Welcome to the newborn assessment. First, we want to gather supplies, clean gloves, and a pediatric stethoscope. We want to make sure that our hands have been washed and that the infant's vitals have been documented. We also want to gain the parent's permission to assess the newborn, and we want to gain the infant's identity from the parents, and then later on we will check the armband or the ankle band to verify this ID. We just don't want to disturb the baby right now by going in and trying to find those things. So first we're going to observe the infant's sleep-wake cycle. And we want to note whether they are in a deep sleep or are they more easily aroused, such as in a light sleep to sound or noise, or are they crying. We want to note that this assessment is being taken on an infant warmer, so they would lose a lot of body heat if they were exposed for a very long time. So now we're just going to note the muscle tone. We want their muscle tone to be moderately flexed. We don't want it to be flaccid or rigid. We also want to note the infant's skin throughout the assessment, and we're going to start with the head. We want to know if there's any bruises or cuts. We want to note, secondly, the sutures on the head. Are they split, approximate, or overlapping? And we're also going to name the infant's bones, the frontal bones, the frontal suture, the parietal bones, and the coronal sutures, the sagittal suture, and then on the back of the infant's head we have the occipital suture with the lambdoidal, the occipital bone with the lambdoidal sutures. And we want to palpate the posterior and the anterior fontanelles. And we want to note whether they are sunken, and that may be caused by dehydration, or if they're bulging. This may be caused by infection, increased intracranial pressure, or even crying. So now we're going to talk a little bit more about skin assessment. The infant may have an irregular pink shape anywhere on the head or the body, and if it blanches, that would be something called the stork bite, and the technical term is telangiectatic nevi. Now if they have an irregular shaped mark that's deep purple or dark red and it does not blanch, this is a port wine stain, and the technical term is nevus flammis, and this is something that would not resolve on its own. So now we're going to talk about the types of swelling in the head. And the first one is caput succedaneum, and this is more of a softer swelling, and this is edema between the periosteum and the scalp, and because of its location it does cross suture lines. Or there may be another type of swelling called cephalohematoma, and this is a collection of blood, so this is more of a firm swelling, and this is between the skull and the periosteum, so it does not cross suture lines. So now we're going to move on to the eyes. The eyes should be symmetrical. The eyes may be swollen from the birthing process. We want to note the character of the eyes. It should be clear. On their sclera, they may have red patches, and that would be called subconjunctival hemorrhage, and that's just a ruptured vessel from the birthing process typically. The eyes shouldn't have any discharge, and the crying should be tearless because their lacrimal ducts have not yet formed. And we just want to check for something called nystagmus, and this would be an involuntary movement of the eyes. So now we're going to move on to the nose. We want to make sure the nose is midline. We want to check for the patencies of the nares, and we do this using one hand. We would lift up the chin, and that will close the mouth, and then we would occlude one nostril by pushing the side of the nostril in, and we would check for diaphragmatic respirations, and we would do this bilaterally. We would also note if there's any nasal flaring, as this would indicate respiratory distress, and we want to assess for the absence or presence of cleft lip. So now we're going to move on to the ears. We want to draw an imaginary line from the outer canthus of the eyes to the top of the pinna. These should meet. However, if the ears are lower set, this typically indicates a genetic abnormality. We also want to note that the infant is responding to sounds, turning in the direction of sounds they hear. And we also want to do something called the cartilage recoil test. This is where we would pull the cartilage forward so it touches the skin, and then release it, and it should immediately go back to its original location. However, with preterm infants, it typically sticks. Something to note. So now we're going to move on to the mouth, so we would apply clean gloves. The tongue should be symmetrical. It should be freely moving. It should not protrude. We want to feel the gums. We want to note the presence or absence of teeth. We want to touch the hard and soft palate and note that. We also want to assess for the suck reflex, and we do this just by inserting our finger about halfway through the mouth. And then we want to actually elicit the gag reflex, and we do this by touching the back of the throat. Next, we want to assess the rooting reflex, and we would do this by stroking the infant's cheek. The infant would turn in that direction, thinking a food source was nearby. And also with the mouth, we want to check for something called circumoral cyanosis. That would be blue around the lips, and this would be a sign of respiratory distress. So now you can remove your gloves. We want to note the chest. We want to note its shape. It should be shaped like a barrel. They should have diaphragmatic respirations, and they shouldn't experience any intercostal or substernal retractions. So we're going to test to see if the clavicles are intact. So we would do this by palpating the clavicle and then doing some range of motion with the arms. And we'd obviously be able to do more with a real infant. And we want to note for the presence or absence of any crepitus. Now if you do this and the infant is screaming its head off in pain, this may indicate that the clavicles are broken. Next, we want to note nipples. They should be well formed and symmetrical. We want to auscultate the heart rate, always in the apical area, which is the 4th or 5th intercostal space at the left midclavicular line. And the typical heart rate should be 100 to 160 beats per minute. Any murmurs that are heard should be reported as they are abnormal. So now we're going to listen to the 5 heart sounds. Second right intercostal space is the aortic valve. Second left intercostal space is the pulmonic valve. Left 4th intercostal space is the tricuspid valve. Left 5th intercostal space is the mitral valve. And lastly, the left 6th intercostal space. Next, we're going to listen to respiratory sounds. They should be clear bilaterally. We want to do this in a set pattern. So we'll begin with the right upper, left upper, left lower, and right lower. And then finally the middle. If you hear any crackles or wheezes, this indicates fluid in the lungs. And if you don't hear any sound, this could indicate a collapsed lung or an atelectasis. So now we're going to move on to the arms. We want to take the brachial pulse bilaterally. We also want to check the infant's grip reflex, and we do this by placing a finger in the infant's hand and they should grasp onto it. This will also be a good time to note the ID band to verify. We want to note if there's any acrocyanosis present, and this is where the infant's head and trunk is pink, however the extremities, the feet and the hands are a bluish color, and this would be common and present for several hours after birth. So now we're going to move on to the Moro reflex. There are 2 ways we can do this. The first way is to startle the infant through a loud sound, and the infant would extend the arms and the legs, and the fingers would curl. Another way to check the Moro reflex is to just ever so lightly lift the infant forward with the shoulders and the back of the head still touching, and then just kind of let go. And that should startle the infant. Their arms and legs should extend and their fingers should curl. So now we're going to move on to the abdomen. The abdomen should be round and non-distended. Shouldn't be any shiny or taut skin. No loops of bowel present through the skin, visible through the skin. We want to auscultate the 4 quadrants of the abdomen, noting bowel sounds. And we want to do this in a set pattern, starting with the right lower quadrant, right upper quadrant, left upper quadrant, and left lower quadrant. Next, we want to palpate the liver. And then we're going to move on to the cord. The cord will have 2 arteries and 1 vein. It should be odorless, it should be clamped, and it should exhibit no intestinal structures. This could be used for a pulse site within the first few days of life. So now we're going to move on to the genitalia. For the infant, female, that is term. Their labia majora should be larger than the labia minora. However, if the female infant is preterm, her labia minora would be larger than her labia majora. We also want to make sure that their anus is intact. And the female infant may have a pink mucousy discharge, and this would be from the mother's hormones. And again, that area may be swollen due to the birthing process. So now I'm just going to get a male infant. Alright. We're We're going to check to make sure that the testes have descended. So we're going to palpate the scrotum, and it should feel like a marble. So here we go. The scrotum should have rugae if it's a mature, term infant. The urethral meatus should be at the penile tip, shouldn't be lower or upper. And also you want to make sure that if the infant's been circumcised, that it isn't bleeding, swelling, or red. You want to make sure that the infant has an intact anus, and again, their first bowel should be within 24 hours of life. So we'll get him back there. All right. Not the best modeling. So now we're going to move on to the thighs. We want to check to see that the thighs, their folds are symmetrical. We also want to take the femoral pulse, and we want to check this bilaterally but not simultaneously. This would elicit the vagus response. Next we want to check the Babinski reflex, and this is where we draw a C upwards and their toes should fan out. So we could do that bilaterally. Fan out. Also, you want to note that the newborn soles should be well lined. We want to check the plantar grip. The infants should grip over the finger. And you'd also, if applicable, note the ID band. So now we're going to check the infant's spine. Spine should be midline, it should be vertical, easily arched. We want to check if there's any sacral dimple or hair tuft, as this could indicate spinal bifida. And typically it is common for infants with darker skin to have spots that appear to be bruises, but they're not. These are called Mongolian spots. And this is something that would resolve, and it's just something to note. It doesn't do any harm. So now we are finished with our newborn assessment. So we're just going to swaddle the infant and hand it back to its mother, or place it in the crib. So we're done.